I'm Professor Dr. Vivek Gupta and cardiologist in Delhi Apollo. And today I'm sitting with one of the very eminent cardiologists of Italy, Europe, or I would say is a globally known figure, interventional cardiologist working in Italy, earlier in Milan. Now, where are you working now these days?
Milan.
Milan only. And he's a father of high pressure stenting, and he's involved in angioplasty techniques ever since it started with Dr. Ulrich Sigwart in 1987. And before that, angioplasty was being done, balloon angioplasty plain, which was started by in fact, the father of angioplasty is Grunzig. So I hope, I'm cardiologist in Apollo. I worked with Alain Crepier. Unfortunately, he's no more, but they're all friends and contemporaries together. Alain Crepier is father of TAVI. He's father of high pressure stenting because that has changed the scenario of complications post stenting what he did. So I would like to start ask him a little about himself and how did you meet Grunzig, and did you meet of course Sigwart is a close friend, but so what was the time of evolution of angioplasty techniques at that time quickly, and then we'll come to the present scenario.
But I started angioplasty in 1982, so at the time where stents were not available. I learned a lot from Jeff Hartler. Jeff Hartler is an American interventionist, one of the first people doing complex PCI, multivessel PCI, and I consider Jeff Hartler as the father of primary PCI in acute MI. At that time, balloon angioplasty was the only approach. Then came directional arterectomy, DCA, which was a good way to improve the result and sometimes to avoid emergency bypass surgery. Emergency bypass surgery was the only approach when you had bed dissection, impending closure. We used perfusion balloons, and if the perfusion balloon did not work, we had to go to surgery. Then came the
And surgery was it was a high-risk surgery. It was a high-risk surgery.
Of course, it was a high-risk surgery because the patient arrived in the OR with ongoing ischemia. Then stenting came, and stenting was a real lifesaver. And the main utilization of stents were Gianturco Rubin and Palma Schatz, and before Palma Schatz we have a self-expanding Medinvent stent and later Schneider. And these stents were used when you had dissection. They were not used to prevent restenosis. Only
it was elective stenting.
It was not elective.
It was not a compulsive
stenting.
Mainly
a
bailout.
Emergency stenting. Bailout stenting.
Yes.
And then we had the two pivotal trials, Benestent and stress trial that evaluated stenting to prevent restenosis. Where bare metal stents and the potential effect over angioplasty was there, but was not dramatic. It was like from 28% restenosis down to 19-20, but nevertheless more predictable, and stenting slowly took over angioplasty. Not completely, but slowly took over because it was easier, simple, and more predictable. The stenting problem was the restenosis because the foreign body caused proliferation, and then arrived the drug-eluting stent. There was a lot of work before arriving of drug-eluting stent. We used various pharmacological approach, radiation, radioactive stents, brachytherapy, name it. Then we had the drug-eluting stent, and the key study was presented by Marie-Claude Maurice at the European Society of Cardiology, Ravel study, published in the New England Journal of Medicine, and the restenosis rate in the study was 0%.
In that study, zero?
Yeah, zero. Unrealistic.
Ravel study.
Ravel.
R-A-V-E-L, yes.
And then drug-eluting stents took over. The Cypher stent was the key, then came the Taxus stent, and then it's the era of routine stenting. So angioplasty became stentoplasty. No balloon unless after balloon you place a stent, which was okay, but now, 20 or 30 years later, we are trying to make a circle in the opposite direction and ask ourselves, is it really okay to place a stent all the time? Even if you have a good result or you have a minimal dissection, why do you have to place a stent, especially now that you have drug-coated balloon that you can deliver the drug to counteract hyperplasia without putting a foreign body. So now we are in the so-called new era or third era. Angioplasty, bare metal stent, drug-eluting stent, and now back to angioplasty. With the stenting, we are not against stenting, but we want to use the stenting in a more selective fashion when needed.
Okay, so you mean to say the era of drug-eluting balloon will come soon, or because I personally feel as of now that a drug-eluting balloon only in the cases where you cannot put a stent, like the ostial diagonal stent, or wherever the size of the artery is less than 2 millimeter, or you have an instant restenosis and you want to catch up with the drug-eluting balloon. So I personally feel, what is your thought process of drug-eluting balloon in the future, in coming years?
I think at the present we already have an established indication for drug-coated balloon in vessel smaller than 3 millimeter. I think there are several randomized studies that show the non-inferiority, and to have a non-inferiority without the need of a foreign body, without the need of long dual antiplatelet therapy.
That's a very important point.
Is already an achievement. So I do not see the role for elective stenting in vessels smaller than 3 millimeter unless you have an impending dissection, unless you have a poor result, big recoil. In vessels smaller than 3 millimeter, drug-coated balloon should be the first choice.
Even in place like proximal LAD?
Even proximal LAD, provided you have a good predilatation result.
But then you have to, you cannot see the minimal dissection unless you do OCT or IVUS. That means without imaging technique.
We don't are afraid of minimal dissection. We don't even afraid of dissections. If you have a dissection and the residual lumen is large and the dissection clears, the dye in the false lumen clears, the dissection can be left alone.
But can you sleep well in the night?
Because you can sleep well. If you have problem with sleeping, there are plenty of sleeping pills. Stent is not a sleeping pill.
So, but you being one of the most promoter of high pressure stenting, you see, till the time when the stent was evolving, only people were going to 8 atmosphere or 6 atmosphere. You started doing 14 atmosphere, and that was the reason why the subacute thrombosis came down drastically.
But this is to make stent better. But if the stent is better, doesn't mean that the stent has to be universal.
This is a very special news from Antonio Colombo. Is a horse's mouth, because I personally don't do this as of now, because I would like to stent electively as people stentoplasty, as you said, stentoplasty. Most of the people are doing it. 99% person. But what do you think is against stenting? What is the thing against stentoplasty?
I mean, first of all, there are 2 ways to use stents. Stents are used to treat a short focal lesion where they were built, and the stents are now frequently used to treat atherosclerosis, to treat diffuse disease, long lesions. Stents were not built for that purpose. Stents were built to treat focal short lesion or dissections. And the two-core extension to use stents to treat long lesions, to treat atherosclerosis in general is not appropriate, because the long-term result of very long stents,
not
even if well implanted, is not very good, because the stent is a foreign body, prevents vessel vasoconstriction, vessel vasodilatation, especially in the LED, close many small septal branches, and it takes away the physiological feature of the coronary vessel. Coronary vessels are not tubes of metal, are living entities. And if you place a short stent, you can make a small jump, but if you place a long stent, you have to cross a river, and it's a different story.
That's why I'm personally against using 42 millimeter, 48 millimeter. A lot of people are using left and right, a very long stent.
Yeah, but they are
treating unnecessarily the atherosclerosis. I see that focal stenosis of 70%. If you have 30% beyond, there's no point to cover that stenosis.
Yeah, but that's the reason why. And especially in India, where you have a lot of diffuse disease, if you have to stent from healthy to healthy, you end up in stenting
48 millimeter tube stents, the whole stainless steel.
Yeah, you see a lot of stents 2.5 millimeter
long, very long.
Long, 40, 42, so even 225 is crazy. Makes no sense.
I can completely agree with you, and I really avoid putting that overall stainless steel point. I want to treat only the lesion, which is actually more than 70%. I don't want to cover just from healthy to healthy.
I mean, if you have to stent the left main, which is 4 millimeter, 18 or 20, it's okay. That makes a lot of sense. It's fine. But even the proximal LED is okay if you want to stent electively. I'm not against. But to do routine stentoplasty, no matter what, I think it's time to get away. But in order to do that, you have to learn to do angioplasty. And unfortunately, many young generation interventionists, they only learn to do stenting. Every time they see a dissection, they react and they believe that every dissection needs to be stented. When you do angioplasty, you have to learn how to distinguish the benign dissection from the malignant dissection.
Without OCT and without IVUS?
Without OCT, without IVUS. Most of the time, you can make the decision based on angiography. We like to use pressure gradient, PDPA, especially when we treat long diffuse disease. In those situations, the pressure gradient gives you an additional reassurance that the dissection is stable. If we find a PDPA that is 0.89, 0.90, and after 1 minute, 2 minutes is 0.91, 0.92, that tells you that the dissection is not impeding the flow or the good flow on the lumen of the vessel, and you can leave it alone. Not that we use PDPA all the time, of course. Angiography is most of the time sufficient, but in some situations, PDPA gives you a further reassurance about the stability of the flow.
That's a great knowledge which I would like to impart upon the young interventional cardiologist. Last question would be, you did lot of complex angioplasties. Complex angioplasties means the patient who otherwise would go for bypass surgery. What is your scenario in Italy? Do you give opinion first option of bypass surgery? Because in India we give always in writing on the file that a patient has refused bypass surgery, then only we go for a complex angioplasty. What is it in Italy? Because you have been able to do a lot of complex angioplasty for not today, even for many years. So do you still tell them to do bypass surgery, or you don't tell them, you just go for angioplasty?
I think it depends. Of course, it depends on the complexity, depends on the Sinter score, depends on the diabetic status of the patient. I think if the patient is diabetic and has a lot of lesions, bypass surgery should be considered, and you have to tell the patient this option and be clear with the patient and tell this option may be superior to angioplasty. I'm not so sure that you can really be firm in talking about mortality, because if you do good angioplasty and you avoid excessive stenting, maybe mortality is not changed. But I think if you have a diabetic patient with complex disease, you have to be clear and tell that maybe bypass surgery is better. But besides these cases, most of the complex disease, except real diabetic patient, you can handle them with angioplasty at the expense of higher revascularization need, second procedure, which may not be a problem.
Yes, because I personally do a lot of complex angioplasties, of course, but I tell them that most of the Indian patients would not like to have bypass surgery, and that is why we succeed in convincing them. I would not say convincing, but we succeed in finding such patients. But I always do. Many times I do stage angioplasty. I always tell my junior colleagues, more than success is safety.
Yeah.
You cannot compromise safety for success.
But I think you have to be fair, and you have to acknowledge that a well done internal mammary on the LAD is a very good option. And if you have long lesions on the LAD with a good periphery, you may consider mammary. I know how difficult it is to implement hybrid, unfortunately, but a mammary on the LAD and a PCI on the other vessel makes a lot of sense.
That is a hybrid procedure. We do a lot of times.
Underutilized. In Italy, is very underutilized, but I believe that this is a very reasonable option in some patients to do elective mammary on the LAD and reserve PCI for the other vessel.
So first PCI or first memory? First memory, of course.
First memory.
This we have been doing a hybrid procedure because you have a small cut on the lateral part of the chest.
Yeah.
And
on a beating heart, no extracorporeal circulation, not expensive, cheap, and quick recovery. And then you do PCI on the other vessel. I
have another example. You see, we did the same procedure for a patient who had a restenosis, and we thought Lima will be better. The patient had some complication post-operative, even with the minimal surgery, and patient is still not come back for the circumflex, which was 95%. Yeah. He will come back. So sometimes these mishaps are there because surgery is a surgery. So angioplasty is much safer, of course. So I was talking to Dr.
It's much safer. It's safer. It depends. I tell you, with a good surgeon, surgery is safer. So I think
one or two such cases, bad cases. I'll give the bad example also. So of course, in Apollo Hospital Delhi, we have having good surgeons and good backup, and we have very good result of 99% success. I work in Apollo Delhi.
Okay.
So I am thankful to Dr. Colombo for giving him time. I know him for last almost 25 years, since Europe PCR used to happen in the tent. You remember the Seine river in the tent area? Yeah. And I was working in 1996 to 98 with Alain Cribier, who was the father of Tavi and a very good friend and very good colleague and very good human being. Unfortunately, he's no more with us, but we have his contemporary. So I always feel that if I'm talking to Colombo, I'm talking to Cribier. Okay. Something like that.
I don't know if I did. I merit this comparison. Cribier made a big change. I did a small change. But anyway, we both worked hard for making our profession better and giving something to our patients. Okay.
Thank you so much, Dr. Colombo and Dr. Vivek Gupta from Delhi on 16th of February 2025. And this will be live. This is already live, but this will go to the YouTube and Instagram and many places. I'll send you the link. Thank you so much.
Thank you.